Welcome to the Explainer. You know, getting a diagnosis of advanced endometrial cancer can feel incredibly overwhelming. There's just so much information. So in this Explainer, we're going to break down the modern, personalized approach into a really clear and simple roadmap.
Okay, so let's just dive right in. A diagnosis like this, it brings up a million questions, right? But the most important thing to know right from the start is that the old one-size-fits-all approach to treatment is gone. We're going to walk through the personalized strategy that doctors use today, and we'll start by getting a handle on the scope of the challenge.
So to really understand the scope, you should know that up to 15% of endometrial cancer cases are what doctors call metastatic, right when they're first diagnosed. That just means that cancer has already spread from where it started to other parts of the body.
Now, historically, the outlook for these advanced cases was pretty tough. The median overall survival was somewhere between 12 to 18 months. But, and this is a huge but, it is so important to see this number as a benchmark from the past. It's a benchmark that modern treatments are now starting to leave in the dust.
And listen, these aren't just statistics on a page. They affect real people. The median age when someone is diagnosed is between 60 and 65, which really helps us understand who is typically facing this journey.
All right, so here's our game plan. We're going to tackle this in 4 simple parts. First, we'll understand the challenge itself. Then we'll get into the cool part, decoding the tumor's unique blueprint. After that, we'll check out the modern treatment playbook. And finally, we'll see how it all comes together to help doctors choose the absolute best path for each individual.
So, let's kick things off with part 1, the challenge of endometrial cancer. The first thing to get your head around is that this isn't just one single disease. It's actually a really complex condition with a bunch of different forms, and each one behaves a little differently. So when we talk about the cancer spreading, where does it typically go? Well, most often, it's the lungs. After that, you've got the lymph nodes, the liver, and the bones. Knowing these patterns is absolutely key for doctors so they can effectively monitor and manage everything.
And that brings us to the most important part of the entire modern approach, our second section, decoding the tumor's unique blueprint. This is the real game changer. The idea is simple. To fight the cancer in the best way possible, you first have to understand its specific genetic fingerprint.
So how do doctors actually create this blueprint? It's a 2-step process. Step 1 is a biopsy, where they look at the cancer cells under a microscope. That's the histology. But step 2, that's where the revolution is. It's the essential molecular testing that lets us read the cancer's actual genetic code.
Now, one of the most critical markers they look for is called dMMR. It sounds complicated, but think of it like this. It's a broken spell checker for the cancer's DNA. Because this repair system is broken, the cancer cells make a ton of genetic mistakes, and that makes them look really weird and foreign to our body's own immune system. That vulnerability, that is a key we can use to unlock some incredibly powerful treatments.
And finding that dMMR status is just the beginning. Pathologists will test for a whole panel of these key molecular markers. When you put them all together, they create this detailed profile, a complete dossier really, that acts as a guide, pointing doctors straight to the most effective therapies for that specific cancer.
Okay, on to our third section, the treatment playbook. This is where we see how that molecular blueprint is put into action. This is the modern arsenal of therapies that are available right now.
For decades, the standard of care was chemotherapy, usually a combo of 2 drugs, carboplatin and paclitaxel. But the biggest recent leap forward has been adding immunotherapy to that chemo. But here's the kicker. Its incredible effectiveness depends entirely on that tumor blueprint we just talked about. And wow, this chart just says it all. It shows something called a hazard ratio. All you need to know is that with hazard ratios, lower is always better. For patients who have that dMMR marker, adding immunotherapy drops the risk of the disease getting worse by a staggering 70%. For other patients, there's still a benefit, but it's much more modest. This one chart shows exactly why that molecular testing is absolutely non-negotiable. But the playbook doesn't end there. If the blueprint shows the tumor is HER2 positive, there are targeted drugs for that. If it's low-grade and sensitive to hormones, hormonal therapies can be a fantastic option. And for some patients where the disease is contained in the abdomen, surgery can still play a really vital role. So for our final section, let's bring all these pieces together. We can now actually map out the clear, step-by-step decision algorithm that doctors use to choose the right path for every single patient.
So it all comes down to this kind of decision tree, and it starts with this one single critical question from that molecular blueprint.
The test looks for dMMR, which we've talked about, or a related marker called MSI high. They both basically tell us the same thing. Is the tumor's DNA repair system broken?
If the answer is yes, the path forward is crystal clear. The combination of chemotherapy with immunotherapy is the standard of care. This is the approach that gives us that dramatic survival benefit we saw in the data just a minute ago.
But what if the tumor is not dMMR? We don't stop. We just move to the next branch of the decision tree. So, the next question from the blueprint is, okay, is the tumor HER2 positive?
And if the answer here is yes, well, that points to a different but just as personalized combination. Chemotherapy is paired with a targeted drug called trastuzumab, which is specifically designed to hunt down and attack cancer cells that have that HER2 marker.
All right, so for patients who test negative for both dMMR and HER2, we just move to the next step. Here, doctors look at the tumor's grade, which means how aggressive its cells look, and whether it's sensitive to hormones.
If the tumor fits this profile, low grade and hormone positive, then hormonal therapy becomes a very, very strong option. It works by blocking the hormones that are fueling the cancer's growth, which offers a less intensive but still really effective treatment.
And finally, for patients whose tumors don't have any of these specific molecular keys to unlock those other therapies, the foundational chemotherapy regimen we talked about earlier remains the standard of care. It's what provides the most established benefit for this group.
You know, when you step back and look at this entire algorithm, it represents a huge leap forward. It turns a generalized approach into a highly personal one, and it's all driven by that initial blueprint. It really raises an exciting final thought. As our ability to map these tumors becomes even more detailed, just how precise and how personal can this fight against cancer truly get?